Yes, very clear,
Okay,
very nice. Yes,
okay. So,
thank you.
welcome everyone. Greetings from Poland. My name is Katarzyna Pawlak. I'm gastroenterologist and endoscopist in the Hospital of the Ministry of Interior and Administration in Szczecin in Poland. And first, I would like to thank our amazing friend, Professor Hussein Okasha, for that invitation. I truly regret I cannot be with you all there on site, but hopefully next year it will happen. And I have unspeakable pleasure to share my talk, which will be on the non-typical features of well-known solid pancreatic lesions and their diagnostic challenges in EUS. So I want to present my case, which will highlight that sometimes the road to final diagnosis of solid pancreatic lesions is very long and curvy. And despite we have a diagnostic workup with computed tomography and even EUS, it may be still challenging. And then we are going to additional tools like SONOELASTOGRAPhy and contrast-enhanced EUS. But even though still it may be a challenge. So in the vast majority of cases of solid pancreatic lesions, we perform EUS guided biopsy because it is the only one right way to establish the final diagnosis for the patient. And here we have the case of 49-year-old male patient with non-functional PNET G1 stage tumor with Ki67 index 1.3%. The lesion was located in the head of the pancreas, and it was diagnosed with EUS guided biopsy. And because of that, the patient stayed under the follow-up at the Institute of Oncology and Endocrinology. And then there was a decision to perform the EUS RFA treatment. The patient underwent that treatment, and the control visit has been set for 3 months. However, due to COVID pandemic, the patient lost the follow-up. So he came back after 6 months to Institute of Oncology and Endocrinology for a checkup, and performed a CT examination, confirmed complete regression of the PNET tumor located in the pancreas. However, there was additional lesion visible in the uncinate process of the pancreas, or the lesion which overlapped the uncinate process of the pancreas, with a suggestion of a lymph node. So that was a morphological suggestion. However, we didn't receive any hard conclusion for the type of the lesion as well as the location of the lesion. And also that lesion wasn't seen in the primarily performed EUS examination. So the patient was sent to our center to perform EUS assessment, and we visualized the solid 7 millimeters in size hypoechoic lesion in the uncinate process of the pancreas with round shape, regular borders, without infiltration, and also without vascularization in Doppler evaluation. So we perform additional assessment with a contrast-enhanced EUS. So we used the contrast agent SonoView, and also here we couldn't see any typical enhancement. So that we couldn't also conclude about the morphology of the lesion, if it's a lymph node, as it was suggested in computed tomography, or is it maybe a NET tumor? So we decided to perform EUS guided biopsy, and the results showed it is NET tumor G1 stage with Ki67 1.6%. So there was a question if the patient may stay under the observation, under the control of Institute of Oncology and Endocrinology, or if we should perform a EUS RFA treatment at the first session for that lesion. However, before we decided on that and go forward, we decided to perform rechecking of the CT examination performed primarily. And actually, we visualized, our radiologist told us and confirmed that the lesion is located in the neighborhood of the pancreas. So that was very surprising because we saw the lesion that is located in the pancreas. And after that, we've noticed in the CT examination that the lesion is located in the neighborhood. So actually, the EUS RFA treatment was not possible in that situation. So that case highlights that sometimes the solid pancreatic lesions differentiation is difficult and challenging. And even we can observe in our daily practice that CT reports as well as MRI reports may be non-conclusive. And given the knowledge and the studies published so far, we know that EUS has very high sensitivity, and it's much higher than computed tomography. It's about 98% in solid pancreatic lesions differentiation. So we mainly refer our patients to that examination as the next diagnostic step. And then we try to find the typical features for those lesions. And here you can see the most common solid pancreatic lesions we can meet an EUS examination. And in the first, for example, when we try to see an adenocarcinoma, to assess the adenocarcinoma, we see it mainly as a hypoechoic lesion, solid lesion with irregular margins, with infiltration, and without vascularization, in contrast to NET tumor, which is very well vascularized, is homogeneous lesion, also hypoechoic, but very well demarcated with round shape. And when we try to estimate the chronic pancreatitis and the pseudotumoral form of chronic pancreatitis, we mainly can observe hypoechoic as well lesion, but heterogeneous one with calcifications, with cysts, with echo-rich strands. And that's a typical view for that kind of lesion. And for example, in solid pseudopapillary tumors, we can observe also round-shaped tumor, hypoechoic, but not so very homogeneous, without the typical vascularization like it may be visible for the NET tumor. So those features we are looking for when we try to assess the lesion and estimate their character. However, sometimes, even though it's not so easy to estimate what kind of lesion it is in EUS B-mode imaging, because most of those lesions are first hypoechoic, and sometimes they are not so typical like here you can observe. And this is the example we had in our center, that in those three types of lesions, we suspected the NET tumor based on the B-mode imaging and additional tools assessment in EUS. And the EUS guided biopsy showed us totally different diagnosis. Like in the first case, it was early adenocarcinoma. That was very surprising. In the second case, it was a lymph node, so that's a very good recognition for the patient. And in the third situation, it was intrapancreatic accessory spleen, so also very good diagnosis for the patient. So that's extremely important, that sometimes it's very difficult to estimate based on those features. And this is extremely important to also remember about potential, malignant potential and malignancy, that even up to 90% of solid pancreatic lesions may be adenocarcinoma, and even if it's not adenocarcinoma, we can have other malignancies here, like metastasis to the pancreas. And we published last year a very nice editorial about that, that mainly we observe RCC metastasis, but also it can be, for example, metastasis of the melanoma, as we published, and other carcinomas. But also here we can have a lymphoma from malignancies, and the management for the patient and the further diagnosis is extremely important to set that management, because the management is totally different in comparison to chronic pancreatitis as well as to autoimmune pancreatitis. So that's the challenge to estimate the final diagnosis for the patient. And what to do to overcome the barrier in terms of EUS examination and differentiation. As it was in our case, we used contrast-enhanced examination with EUS, and that was helpful. And also sometimes we can use sonoelastography to try to estimate the character of the lesion. So what is known about those two methods? When it comes to EUS elastography, the meta-analysis found a very high pulse sensitivity. However, the specificity was lower for that method. And given that the elastography may be only used as an additional non-invasive technique in lesions characterization, and for example, for contrast-enhanced EUS, that method found a quite high sensitivity and specificity, especially for pancreatic cancer and the lesions below 2 centimeters in size. And especially when we compared that method to computed tomography, that sensitivity was only 50% for computed tomography in that case. And also, of course, for NET tumors, it may be very, very helpful because sensitivity is about 95%. So concluding, we know that combination of these both methods, mainly contrast-enhanced EUS and elastography, has very good results, especially in terms of high negative and positive predictive value. So that's very good to differentiate the lesion and to estimate the diagnosis. However, as I mentioned at the beginning, in the vast majority of cases, it's not enough because we need to know what is the histological result of that lesion. So we're using those methods as well as in combination with EUS biopsy, and we can achieve very high accuracy, even up to 95%, in terms of differentiating, especially ductal adenocarcinoma with other solid pancreatic lesions, like NET tumors, metastasis, and pseudotumoral form of chronic pancreatitis, and even intrapancreatic accessory spleen. And I would like to just show you two studies which were published last year and this year, extremely important when it comes to using additional tools for EUS guided biopsy and if it's helpful. So that study was comparing the contrast enhanced EUS guided biopsy with a conventional EUS group and for solid pancreatic lesions. And that study showed that actually contrast enhanced EUS guided biopsy sampling was not superior to conventional EUS. So actually there is no need to be used it in routinely daily practice. However, it may be an option for some lesions and for small lesions, especially indeterminate ones. And the last thing, the study published this year also, which compared the different type of needles. This is also our question every day: what type of needle we should use for EUS guided biopsy? And actually, that meta-analysis showed that none of tested needles resulted significantly superior to the other FNB or FNA with Rose method. And actually, this is what we do in our daily practice. We practically use FNB needles like Francine or fork tip needles, especially 22 gauge, and it was confirmed that those lesions showed highest performance for tissue sampling in pancreatic masses. So there is still a lot of questions. However, I know that we are close to perfect diagnosis for the patient with EUS and EUS guided biopsy. I thank God we have those tools to assess it, and that's it. Thank you so much for your attention.